Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Considerations for Implementation Selection of Treatments in CLL, SLL. This training is geared towards the healthcare professionals. Today, Dr. Banerjee will provide a background and a treatment overview of CLL and SLL. Let me introduce myself. My name is Desiree Naylor, and I am the Community Services Manager for the Prairies region at the Leukemia and Lymphoma Society of Canada. I'll be the host of this pre-recorded event. Before we begin our main presentation, I'd like to share with you our mission and highlight some resources that might be helpful for you or someone you know. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. Ultimately, we are here to serve the community. We offer guidance and support to people affected by blood cancer every step of the way. We offer a variety of educational resources and services for those affected by blood cancers, as well as healthcare professionals. In addition to disease information booklets, fact sheets, and videos, we also offer other valuable services such as our peer support program, virtual support groups, a multitude of webcasts, a podcast, a COVID-19 resource center, and access to our community services managers in every region. We invite you and those affected by blood cancers to visit bloodcancers.ca for more information. So what can we do for you as a healthcare professional in our communities? First, we offer free tear pads to help facilitate patient referrals to LSC and our services. You can order your very own tear pad by calling toll-free or by email at info@bloodcancers.ca. We also have a mindfulness or self-reflection journal available for download on our website. This can be a great tool to offer those affected by a blood cancer, no matter where they are in their cancer experience. Moreover, we are growing our continuing education program. This program is aimed at healthcare professionals like you and provides access to training in a self-study format. You can watch them whenever you want at a time that is convenient to your schedule. You also have access to a CLL mentorship program for nurses. What is the nurse's role in management of the CLL patient when initiating treatment? Or what are the main side effects to watch out for when initiating treatment with targeted therapies? These questions and much more can be discussed with our mentor, Tracy Remingbold. Tracy is a research nurse manager at the Clinical Research Unit of the Jewish General Hospital in Montreal. She has over 20 years experience working in hematology and with patients. To know more about these training webcasts, visit the website on your screen to learn more. We'll continue to add new material to the roster, so be sure to visit our website regularly or watch for our emails with updates and information. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by a blood cancer cope with anxiety and isolation during these times. Please do not hesitate to refer your patients to a community services manager in your area. It is now time to introduce our speaker, Dr. Banerjee. Dr. Banerjee has an undergraduate degree, clinical training in medicine and hematology from the University of Manitoba. She completed additional training in translational research at the Dana-Farber Cancer Center and the Broad Institute of Harvard and MIT. She is the co-lead of the CLL clinic at Cancer Care Manitoba and University of Manitoba. She is the principal investigator on clinical trials and has the interest in following clinical cohorts to understand the real-world experience with novel treatments for CLL. This includes their implementation, the understanding of how patients tolerate these new treatments, and the impact of dose reductions. She also evaluates the economic and resource impacts of these treatments. Over to you, Dr. Banerjee.
Thank you very much for that kind introduction. So the title of my talk is Considerations for Implementation and Selection of Treatments in Chronic Lymphocytic Leukemia or Small Lymphocytic Lymphoma. So I'd like to first start with an acknowledgement of the traditional treaties and territories. The University of Manitoba campuses are located on original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and the mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I would also like to pay tribute to those impacted by COVID-19. These include the patients and families that have suffered due to the illness COVID-19, and thank patients who continue to participate in clinical trials. I would also like to thank all healthcare providers for their dedication, hard work, and sacrifice in these difficult times. These are my disclosures. I receive funding from multiple pharmaceutical industries and serve as a consultant, but I also have lots of national and international grant funding for research endeavors. I hold a patent, which is irrelevant to this talk, and I will be speaking about drugs that are Health Canada approved, in addition to those that are funded in the Canadian environment. All my treatments will be based on evidence that is present in the literature. So first, a background overview of CLL. And the second objective of this talk is an overview of the treatment, the decision tree, the types of treatments, algorithms, and implementations that are now leading to the cutting edge changes in standard of care. So let's start with the background. And I know many of you are familiar with this, but just to provide context to the second half of the talk. So CLL and SLL belong to a cohort of lymphoproliferative disorders that are defined by the presence of a monoclonal B cell, which expresses CD19, 20, 23, and 5 on its surface. In patients who have less than 5 to the 10 to the 9th cells in the peripheral blood with no evidence of any abnormalities within the complete blood count or evidence of clinical findings such as nodal involvement or a large spleen, these patients would be defined as monoclonal B-cell lymphocytosis. In patients who, again, do not have a high number of circulating cells within the blood, but have nodal disease or enlarged liver or spleen, may have a diagnosis of small lymphocytic lymphoma once confirmed by a biopsy. For those who have high white blood cell counts and in which a monoclonal population of these B cells is circulating that is greater than 5 times 10 to the 9th per liter, they meet the criteria for chronic lymphocytic leukemia. So approximately 2,600 new patients are diagnosed in Canada each year. An average age of diagnosis is 72 years, but in clinics it may be younger, such as ours, where it's 68. It is more common in men. There's no known cause, and by all definitions, it's still considered an incurable cancer, which is why there is an unmet need to provide excellent treatments for this disease. So the staging has been the classical way of determining prognosis, and this can be done by simply looking at the CBC and is there an elevated white blood cell count? Is there evidence of lymph nodes on clinical exam or a spleen? And what is the impact of these cells on the bone marrow? Have they caused a significant infiltration leading to decreased numbers of red cells or platelets? And this is important because we've traditionally used clinical staging in chronic lymphocytic leukemia as a means to determine prognosis. And in a time where we weren't able to define true bone marrow involvement or had multiple other competing factors, whether it was kidney function being impaired or other medical illnesses or autoimmune complications, this led to a significantly reduced overall survival or median survival for patients with RISE stage 3 or 4 disease. And here on this chart, you can see it was somewhere around 20 months. But in an updated analysis, looking at a larger number of patients, we can clearly see that the patients with low-risk disease, such as RISE stage 0 and 1, have a significant median survival somewhere over 100 months, whereas those who have had RISE stage 2, 3, or 4 have median survivals anywhere from 58 to 88 months. And this is important as we embark on this next journey to determine what are the best prognostic features when we look at chronic lymphocytic leukemia. So one of the greatest improvement in identifying prognostic markers has been some of the underlying biology that leads to progression in CLL. And most of this is a result of either losing a brake or a tumor suppressor gene, or pressing on the accelerator or increased number of genes that promote tumor growth, such as oncogenes. So one of the main tests that is used to determine which treatments are best suited for a patient is something called fluorescence in situ hybridization. And it is a ability to detect chromosomal abnormalities by using a series of 4 probe sets that include abnormalities on 4 different chromosomes. You can evaluate the presence of a 13q deletion, a 17p deletion, an 11q deletion, or the presence of trisomy 12. Some clinical laboratories will look at all 4. Other will look at the 2 highest risks, which are the 17p and the deletion 11q. What is important to note is that 80% of patients will harbor at least one of these abnormalities. So what does this mean for your average patient? Well, the 13q deletion is the most common, and it's found in 50 to 60% of patients. But what I think is less known is the fact that it also leads to a deletion of microRNAs that lead to increased BCL2 expression. And this becomes relevant because one of the drugs we're now using, which is known as VENETOCLAX, is targeting BCL2. So we might start to see differences in how people respond to treatments based on the presence of 13q deletion, which hasn't had a lot of predictive outcome so far. Deletion 11q is always includes the ATM gene, which is part of the DNA damage response. It's present in less than 10% at diagnosis, 20% at treatment, and in about 30% of patients at relapse. The 17p deletion leads to loss of p53 and frequently pairs with a loss of the second allele, meaning that although you had one functional allele, you may have developed a mutation without losing part of it on the chromosome. Trisomy 12 leads to amplification of Notch1. And so we're starting to learn more about the role of Notch in the biology of chronic lymphocytic leukemia, and so may again have implications for future response to therapy and development of other complications such as Richter's transformation. The most important thing about FISH is that it changes with time and it is not static. So traditionally in our clinical practice, we do the testing not at diagnosis, mainly because we don't want to be repeating these tests over and over again, but at the time at which a patient requires treatment. This may change if it predicts better outcomes by doing this earlier, but right now we have no evidence that this is the case, as we only treat our patients when treatment is required. And so what we can see here is the frequency of the presence of these mutations. And as I said before, the 13q is the most common. So we're now looking at, instead of looking at the large scale of the chromosome abnormalities, one of the things that many of us across the country are starting to get access to is the ability to sequence the gene for mutations itself. P53 is very important as it enables us to determine if a patient is going to be susceptible to chemotherapy treatments. And so it is very important to know how to classify a patient, whether they're low risk or high risk. And if we do FISH testing, we'll capture the majority of patients, but there's some patients we would miss because the only abnormality they might have is at the gene level and not at a chromosomal level. So P53 mutations are present in 4 to 8% of new patients, but can rise to about 10% at the time of first treatment. It's present in 30 to 40% of patients at relapse. And what is important to note is the median overall survival with traditional quote unquote chemotherapy has been in the range of 3 to 5 years. And this is considered less than 70% of the expected survival of the general population. And that's a key important thing to understand. And again, it can change with time. So these are abnormalities that can be acquired over time. The next thing to talk about is the immunoglobulin heavy chain mutation status. And this one can be a little bit confusing at times because we talk about whether someone is mutated or unmutated. And so unlike a gene abnormality that we've been looking at where a mutation is bad, having your immunoglobulin rearranged or mutated is actually a good prognosis feature. And the reason for this is that the mutated IGVH represents a more mature, more calm, and a quiescent cell, opposed to the unmutated status, where the cell is considered immature, impulsive, and has a lot of the features of early hematopoiesis where they can replicate and divide, akin to other acute leukemias. So what are some of the facts about IGVH mutation? The IGVH mutation status affects how quickly a patient relapses after treatment with chemotherapy. And we know that unmutated patients have a higher rate of relapse. 50 to 60% of patients with an IGVH mutated status will have durable remissions, and some of them don't relapse and can survive for a very long period of time, and in some cases have actually had cure with their chemotherapy-based treatments. Whereas all patients with unmutated IGVH are projected to relapse with chemotherapy. And we're now looking at subgroups of patients and how they respond to novel agents in many of the clinical trials. And some are already reporting that targeted agents are better for patients with not just the high-risk features with chromosomal abnormalities such as 17p or p53 mutation, but also with IGVH unmutated status. Novel agents, as I've mentioned, can be best for those with the unmutated IGVH. The one important feature about this is that the results do not change over time. So how do we integrate all of this information together? So there's some pretty standard lab tests that your laboratories can do to help create what's called the CLL IPI score, or the International Prognostic Index for CLL. And it takes into consideration the IGVH status, the 17p or p53 mutation status, the beta-2 microglobulin, the Rye staging, and the age. And all of these parameters are given points. And a patient can be categorized as either low risk, intermediate, high, or very high. And you can see here, if someone has low risk disease, their 5-year overall survival is somewhere in the range of 93% at 5 years and 79% at 10 years. And this can get very low by the time they're in the very high risk categories, down to 23% at 5 years overall survival, or 3.5 years at 10-year overall survival. And what's important to take home from this slide is that these outcomes were based on response to chemotherapy. And our treatments have changed so drastically that we don't actually know what these numbers look like in the presence of novel treatments, which is very important, but gives us the reason to understand why we might be transitioning from chemotherapy-based therapies to these novel treatments. So objective 2 is treatment overview, the overview of CLL treatment and changes in standard of care. So really important to know that CLL is a chronic condition that may require long-term treatment. And it's important to know that, like we said, the median age at diagnosis is high in the 70s, and 90% of patients are diagnosed over the age of 55. And 89% of patients have at least one comorbidity at diagnosis. And the disease itself is rarely curable, but can be treated very well, improving quality of life for all of our patients moving forward. So what is the approach to the CLL patient? Remembering that it is not a curable disease, but indeed treatable, our first goal is to do no harm. And because for most patients who are older, it is incurable, we want to ensure that our goals are focused to maintain their quality of life and improve. And some of this occurs by simple observation. So a lot of times the term watch and wait is used, but active observation is what we're doing. We're monitoring them for symptoms that may develop over time that require us to intervene, or complications of the underlying disease, such as recurrent infections, the symptoms of fevers, chills, night sweats, nausea, vomiting, those typical cancer symptoms and weight loss. Advanced stage disease. So if we're routinely surveying patients and monitoring their blood counts, we can see their blood counts change over time, and we can intervene when we start seeing changes in their blood work before they present with dire complications of low blood counts. And obviously, because we're monitoring them at a regular interval, we can evaluate other parameters such as lymphocyte doubling time or large bulky disease that might mean that we need to treat them. And always thinking in the back of our minds is that there are some more intensive therapies that are available for patients. I put an age limit here, but those age limits are being pushed and pushed as we have older fit patients that might be eligible for some of these intensive treatments. So traditionally, we've used age and cutoff of greater than or lower than 65. We've used fitness as a measure in clinical trials and has often been used to decide which chemotherapy agent can be used for treatment. And then obviously organ function in general is important. I've listed kidney function here, but there might be other organs such as liver that might be important in determining which patients should get which therapies. And the primary goals have really been effective long-term disease control, symptom management, and of course, tolerability. And I think that's one of the things that we have sacrificed for treatment in itself because we didn't really have other options. And so I think that's going to be very important to incorporate as it also improves the patient's goals in trying to be partners in their treatment so that the best treatment is being offered, the best tolerable treatment is being offered that enables the patient the best options for quality of life. And so you can see here this change in the treatments of CLL over time. And it was very easy to administer a lot of these treatments because there were intravenous treatments that were given at your cancer center. And because this is done for all treatments at all cancer centers, it was not difficult to adapt these into our regular practice. But starting 2010, 2013, and 2018, we had a series of oral therapies that are being dispensed, which led to some challenges. Who to dispense it? How does it get to the patient? And who's responsible for those dispensations? And that depends on province to province. And then combining an oral treatment with a monoclonal antibody after you've gone to an oral treatment. And then the duration of treatment all became challenges that we had to deal with. And with these new treatments also came new challenges in not just the effectiveness of the drug and the delivery of the drug, but how to access some of these treatments, what is required for that. So the need for molecular testing and also the geography on where we can administer certain treatments. All of these questions started to enter our practice as physicians. So we've known all about the chemotherapeutic agents, but let's spend a little bit of time on some of the targeted agents. So targets that hit the B-cell receptor signaling pathway, or the BCR, can be classed clinically, I think, into two broad categories: BTK inhibitors and PI3 kinase inhibitors. And for the most part, the most success has really been with BTK inhibitors from a targeted oral agent. So BTK inhibitors are ibrutinib, acalabrutinib, zanzabrutinib, and LOXO-305. Ibrutinib and acalabrutinib are front and center in the Canadian scene, but coming up close behind are zanzabrutinib and LOXO. From a PI3 kinase perspective, idelalisib is an approved therapy in Canada. It's to be used in patients who are not tolerating a BTK inhibitor or in the relapse refractory setting when there's no other options. Some of the challenges have been implementation of this therapy due to side effects. For the purpose of this talk, I will not be talking about PI3 kinase inhibitors until they become more common in our day-to-day practice. Monoclonal antibodies have also gone through an upgrade, so to speak. So we've all got experience using rituximab, but 2 new antibodies are one of them that is approved and one coming down the pipeline, which are thought to be even more effective and powerful than rituximab. So the one that we'll focus on in today's talk is obinutuzumab. And finally, a new targeted agent that has really been used either in the relapse refractory setting as a single agent or in combination with a monoclonal antibody is VENETOCLAX. And if we understand the biology of chronic lymphocytic leukemia, we understand that it is mainly based on a defect in apoptosis. And the whole idea is that VENETOCLAX enables this natural process of apoptosis to occur so that the CLL cell can die a natural death. So here is an algorithm that takes into consideration the molecular testing, the various treatment options that are available in the Canadian environment, and then I'll spend a little bit of time going through them. So if we look at the red blocks, I think this is the early stage asymptomatic patient that I talked about, where all of these patients are observed regardless of their molecular profile. However, if someone starts to develop active disease or symptoms, they are then classified into these categories of fit, unfit, and frail. And these categories are becoming more and more blurred with time, but for the purposes of our time at this point, these divisions still exist in the Canadian environment. And so it's important to put it in that context. That being said, after that, it's important to look at what the options are, and that is based on the molecular testing. So in someone who has mutated IGVH and does not have a 17p or p53 mutation, these patients, could be eligible for chemotherapy with FCR. There's data suggesting that maybe these patients should also have the option for time-limited treatment with VENETOCLAX and obinutuzumab, or they should also have the ability to have access to BTK inhibitors, which have already been proven in a randomized control study to be more effective than standard chemotherapy. But those who are high risk definitely should be getting a non-chemotherapy based treatment such as VEN-O or BTK inhibitors. And that same rule really applies to the unfit patient population where chemotherapy is less of an option because each of these drugs, VENETOCLAX and obinutuzumab or acala or ibrutinib, have basically in randomized phase 3 studies been more effective in progression-free survival advantages for those patient populations. And in those who may not be able to tolerate an intravenous-based therapy or some of the implementation challenges of some of the targeted agents, either simple treatment with a BTK inhibitor or even some chlorambucil may be still an option. So what I didn't mention here is that the P's in every portion of the slide mean there may be a discussion with the patient as to what exactly can they do in this partnership, what are the barriers for them picking one treatment over another. And I think it's very important for us to explore those because there may be ways for us to help in them accessing any treatment that they're eligible for, but also taking into consideration the fact that every province has what's approved for their patients. And so although there may be some discussion, there may not always be a clear-cut choice, and specifics scenarios may have to go to each of the patients' funding bodies, provincial funding bodies, to determine what that might be. So keeping that algorithm in mind, here is some of the updated data that looks at targeted therapies in the frontline setting. And it's clear compared to all the chemotherapy backbone standards that whether it was a BTK inhibitor or a targeted agent such as VENETOCLAX, the median progression-free survival was increased in all these targeted agents, even after prolonged follow-up after 4 years. And they're very similar across the board. And I think that's important message that we will be transitioning to these targeted therapies more and more based on this evidence. And as the evidence matures, we'll still see these drugs for a long time to come. But this causes us the need for a pause. So the cause for pause is the title of this slide. And the reason for that is if you think about chronic lymphocytic leukemia and its treatments, and when chemotherapy was the standard backbone, it was 6 months and then you were done. There was no treatments to be given until a patient relapsed, or more intensive treatments if we saw that patients were progressing on active therapy. And here, we are now moving to more effective treatments, but keeping in mind patients are on therapy for a longer period of time now. And that comes with multiple balances that we have to understand. Continuous therapy have better efficacy than time-limited therapy, but you're on these treatments longer. What happens when you're on treatments longer? You have increased costs, and we have to be respectful of the environment that we live in, and that is our governments are paying for these treatments for our patients, which we are very grateful for, but at the same time, we have to make sure that what we're doing is the best treatments for those patients. And so we have to think about those costs so that we can provide care to everyone. But it's not just the costs, it's also the side effects that the patients are experiencing. So the costs are not just financial costs, there are also people costs involved in this. And so we need to make sure that the goals of therapy align with the patient values as well. And so we have always been in the mode of reserving our best therapies after someone fails a whole bunch of treatments. But I think in the CLL world, the mindset is changing and it's moving our best treatments up front. And if we think about that mindset changing, it also may have to do with the biology of the disease as well. So let's say we talked about all these genetic abnormalities that patients can have in their tumor cells from the very beginning, and we allow them to continue to grow over time. And what we don't know and we haven't measured overall is, are we enabling more genomic instability to lead to a more aggressive disease at the time of treatment? And so by using our best treatments up front, are we stabilizing the CLL genetic landscape? And are we providing patients a different relapse in the future? Or maybe they won't relapse at all because we're not actually allowing them all this time to gain this genomic instability. And these are questions that are being answered as we speak. Multiple clinical trials are evaluating this. But for right now, I think what's important is this balance of time-limited treatment, reducing toxicities to the patient, and giving them access to the best treatments first. So again, this is the algorithm, and so we talked about that already. And so let's focus on the continuous therapies with a BTK inhibitor. So as I mentioned, BTK inhibitors are acalabrutinib and ibrutinib in our current landscape. And in my clinical practice, when I see them, the patient, I want to make sure that their clinical history enables us to implement this treatment. And so what I do at baseline is to provide a patient with an EKG. I review their blood work, and I start allopurinol approximately 3 days prior to treatment. And the 3 days is relatively arbitrary, but it's because it's standard for VENETOCLAX in our institution. So the idea is just to keep it same for everybody so that we're not worried about confusion in the future. All right. So one of the concerns with ibrutinib initiation is that the white blood cell goes up. And so this is actually a graph of the white blood cell, but I think the axis doesn't show that. And so this is a standard effect with BTK inhibitors as a class. And so it's not something that is concerning, but just needs to be monitored. Because eventually over time, what happens is the white blood cell count falls and the hemoglobin and platelets improve. So this lymphocytosis is observed in 69% of patients, and it resolves in 77% of these patients. And like I said, it is a class effect. So although it's mentioned here with ibrutinib, it also happens with acalabrutinib. But I think some of the more concerning concerns with this class of drugs is the effect on bleeding, the heart, the skin, and nail changes. And so here, BTK inhibitors as a class have the ability to cause bleeding through platelet dysfunction. They can cause atrial fibrillation, but the effects of those side effects are reduced in the second generation of this class of drugs. So drugs like acalabrutinib have a much lower incidence of atrial fibrillation, somewhere in the less than 10%, opposed to ibrutinib's 20%. Ventricular tachycardias are something that are a concern with ibrutinib. And then some of the off-target effects, such as paniculitis and nail changes and paronychia, which are mediated through an EGFR-mediated toxicity. And so it was an excellent drug and has excellent efficacy, but it also caused our practice to shift to try and manage a lot of these side effects. And so drugs that became available in the second generation in the frontline setting hadn't actually been compared to the relapse refractory setting. And so we wanted to know whether our observations in the clinical setting were actually just observations, or was there a real difference between the two generations of drugs, their efficacy, and their tolerability. And so this was a randomized study of ibrutinib and acalabrutinib that was just presented at ASCO. And there's 533 patients accrued in this study. The median age is 66, and patients had at least 2 prior therapies. And they were highly, the population was very high risk in terms of its molecular profile. I think what is very important with this study, opposed to some of the other studies, is that the median follow-up was about 40 months. And what this showed was that the median progression-free survival was no different in both of the arms, which then allowed them to look at the safety endpoints because their primary endpoint was met. And what they found was that atrial fibrillation occurred in 50% the rate compared to ibrutinib, that the rates of infections were similar between the two, and that there was no difference in Richter's transformations, which were the 3 main categories of their secondary endpoint. But I think a lot of people wanted to know the rates of hypertension and the rates of bleeding. And I think it's important to demonstrate that the rates of hypertension were also lower with acalabrutinib, and the rates of bleeding were also lower. And so when choosing which drug to implement, I think that becomes a big consideration. Am I going to have to manage other side effects for these patients? And that might make picking one of these drugs important. It also might mean that someone who is remote and rural may be safer to receive one of these treatments, as their risk of developing a side effect is lower. So what we used to do was, as per the clinical trial for ibrutinib, and that was weekly monitoring times 8. We don't do any of that anymore. But now what we do is we do a CBC and biochemistry at week 1, 4, 8, and 12, and then we see them every 3 months thereafter. And so the week 1 assessment is actually a nurse assessment. It can be via phone or it can be in person. And the whole idea is, are you tolerating your medication? Do you have any side effects? And then we usually assess at week 4, 8, and 12 to determine response by clinical examination and review of blood counts. And again, to determine whether or not there's any toxicities. And our assessment consists of evaluating the vitals, because the pulse and the blood pressures are equally important as the rest of the evaluation. And then the physical exam to determine nodal response, and skin, nail changes, and evidence of bruising. And the reality of the situation now is, with the second generation inhibitors, I don't really see that change. So that brings us to the use of VENETOCLAX. And VENETOCLAX has always been either as a single agent or has now entered, based on the MURANO study, in combination with VENETOCLAX and rituximab in a time-limited manner where rituximab is delivered for 6 months and then the VENETOCLAX is on for a 24-month period. And clearly compared to the comparator arm here, which was bendamustine and rituximab in the relapse setting, the VR had a better outcome, both from a progression-free survival and an overall survival setting. So then why not use VENETOCLAX in the frontline setting? And so the CLL-14 trial really demonstrated that we could, and not only could we use it in the frontline setting, we could actually reduce the time on VENETOCLAX to 12 months. And this becomes very important when we're thinking of costs, toxicities, and time off drug for patients. So we went from talking about BTK inhibitors, which are continuous in nature, to now talking about time-limited therapy with novel agents that don't include chemotherapy, which is exciting, but also daunting when you think about implementing these treatments in your clinical practice. So in the frontline setting, the VENETOCLAX and obinutuzumab also demonstrated a progression-free survival advantage compared to the standard arm of chlorambucil and obinutuzumab. VENETOCLAX has a risk of tumor lysis associated with it, and this leads to electrolyte imbalances, renal failure, and cardiac dysfunction, while obinutuzumab has the risk of infusion-related reactions associated with it due to cytokine release and can lead to some hemodynamic instability. And I have to say, as a nation, I believe the uptake of obinutuzumab, even though chlorambucil and obinutuzumab has been around for so long, has been actually quite limited because of the wide use of bendamustine and rituximab in patients and the ability to deliver rituximab easily subcutaneously compared to obinutuzumab. And so these might be some of the transition challenges that we're seeing with increased use of VENETOCLAX and obinutuzumab in a larger proportion of patients. So most of you are familiar with the ramp-up schedule of VENETOCLAX, and so this is here for your review, but it's a 5-week ramp-up period based on dose, and patients remain on a set dose over a week at a time. And this dosing is subject to how it's administered, either as an outpatient with some close monitoring or as an inpatient based on the product monograph if you are deemed to be low, medium, or high risk for TLS, and those criteria are listed here. One of the things at my institution, which is difficult, is getting a bed to admit anyone for any treatment in this regard. So adjustments have to be made to be able to deliver some of these treatments as an outpatient. And so when I talk about access to therapy, this is one of the things that I want to highlight, is that you can work with your organizations to help improve delivery and access to treatments anywhere in your province. And so for the last 4 years, our administration of VENETOCLAX has really been limited to our larger center. But I'm proud to say in the last few months, we've now started to be able to administer VENETOCLAX in close collaboration with other centers under the supervision of some of our family practitioners in oncology. And so that's exciting, not having patients having to travel to Winnipeg for their treatments. So these are some of the things that I wanted to share with you today. So this is what the ramp-up pills look like. And it's important to note that the 20 milligram dose is 2 10 milligram tablets. So in patients who are upfront and not actively relapsing in the relapse setting, if you have difficulty onboarding the medication at the 20 milligram dose, one of the clinical things that you can do, and it was done in some other studies, is start at 10 milligrams and then evaluate their risk to develop tumor lysis based on the lower drug. So the idea behind obinutuzumab starting on cycle 1 was that you could debulk a patient prior to receiving VENETOCLAX-based therapy, and this would enable a easier transition and reduce the risk of tumor lysis. But from a practical implementation point of view, this can be very difficult. And so what I'd like to share with you is that we have created a reference regimen order that we would be happy to share across all your institutions. And so you can contact us at Cancer Care Manitoba, and our pharmacy department would be very happy to share this with you. And so what we've done is created a schedule and a reference regimen order on how to deliver obinutuzumab in combination with VENETOCLAX. And so, like I said, we start the allopurinol 3 days before, and we encourage the patient to drink 1.5 to 1.75 liters of water every day. And then we administer the obinutuzumab. And so I think one of the things that is important to note is that we deliver obinutuzumab in a different manner than most protocols that are published. And we have some experience using it and have a publication that's coming out to look at a reduced rate of obinutuzumab infusion to enable patients to go through their treatment without a significant infusion-related reaction. And we found that this helps reduce the infusion-related reaction. And so on the second day, you can see that the obinutuzumab is dosed very slowly, and this again enables us to prevent the infusion-related reaction. And although it may take more time in the chair, the fact that you're not dealing with an acute complication where someone's blood pressure drops or they're feeling unwell, I think is beneficial to everybody involved, especially the patient. And then for day 8 and 15, we do the standard dose. And then day 22 is when we start the VENETOCLAX ramp up. And so here we actually have what time we tell the patient to take the pill and then what time to come in for their blood work to be monitored. Now, sometimes patients will stay at Cancer Care Manitoba until we say that they can leave. Your institution may choose to do something differently, but these are just pointers that you can use to adapt to deliver this treatment for your patients. And then on cycle 2, we now have the ability to deliver obinutuzumab via rapid infusion. And so not only can you give it via slow infusion, you can also do it in rapid infusion. So the price you pay for that really slow time on the very first implementation, now you're able to deliver this to your patients much, I would say, safer and with their perspective also in mind, that they're not undergoing significant symptoms associated with the drug induction. So it's really important to know that a lot of our patients have multiple comorbidities. And so picking the right treatment, which is best for the patients, is really important. And so, you may decide to pick a treatment based on the molecular profile, and then further refine that treatment based on the patient's comorbidities. So closing remarks, it's an exciting time in CLL, and we're trying to position our best treatments first. We're taking into consideration the patient viewpoint, which I think is very important, in addition to the standard molecular and funding criteria that we have to implement. But as a society, we want to make these treatments more accessible, and finding ways to deliver these treatments both to the patient where it's safer and closer to their home with equal access to any treatment is something we are very much looking forward to and hope to collaborate with others in achieving the same goals. So with that, I'd like to leave you with a lot of hope for the future of CLL. Thank you very much.
Thank you so much, Dr. Banerjee, for this interesting presentation. I'd also like to thank Avi for helping to make this webcast possible today. Before signing off, I'd like to remind everyone that we are here for you. Do not hesitate to contact the LLSC if you need more information. You can reach us by email at info@bloodcancers.ca or toll free at 1-833-222-4884. Also, make sure to check our website regularly to watch all past webcasts or for the dates of upcoming webcasts. Thank you for attending and stay safe.